Hello, pod people. I am Mike on the mic, Mike Sokolowski, coming to you with this episode of Home Care, you say? Thrilled to be joined by two friends and colleagues, Dave Totaro and Bill Dombi. We are going to do a deep dive and maybe some reminiscing and high gloss overs on the last 15 to 20 years in home care advocacy. Before we get started, in all transparency, everyone listening should know we are all three of us fans of the greatest sports team in history, the New York Yankees. And Bill, I want to mention this before we get started that, do you know, the retirement of Dave Totaro could bode well for us this year because the last time the Yankees won a World Series is right before Dave started at Beata Home Healthcare, just so you know. So I see this as a key.
Well, that certainly speaks to his length of tenure, at Beata. And I have always suggested Dave consider going in as a designated hitter for the Yankees. I think he could change the whole dynamic.
Yeah. Well, Mike, there's no coincidence in that because I had to step down from the Yankees back then in 1996 in order to start with Beata. And now that I am retiring, I can rejoin them again for this coming season.
See, I knew there had to be a connection. I wanted to get that out of the way and clear it up and just know that we will be the 2026 World Series champs. So let's jump
just so that you're aware of this, Mike, I've got Mickey Mantle looking at me right now. I've got a signed picture of one of the greatest Yankees ever just to my right here. So I'm feeling a little bit insecure at this point between the giants of Mickey Mantle and Dave Totaro.
It's hard. It's going to be hard. You're going to have to focus really hard during this. Let's jump right in. Bill, we're going to tee this up to you first. What upcoming legislative or regulatory changes do you see having the biggest impact on home care in the next 2 to 3 years?
Well, I'm going to give you a list that breaks it down by sector, okay? Because when we look at care in the home, it's a broad breadth of great services that are there. We'll start off with, one that's probably in a fairly high risks category, and that is home health under the Medicare program, and particularly related to the payment rate issue. It's been around for a few years with the new patient-driven groupings model, but even if the home health community gets through PDGM, that does not mean the end of the kinds of challenges that will be there relative to payment rates. And it seems that home health and other sectors in the Medicare program are on a permanent status of payment reform, payment adjustment, and adjustment often translates to payment cuts. So assume we get through the PDGM part, I would put down in my ledger of what to watch for is a rebasing of payment rates. Rebasing it, which focuses in such things as, the margins the home health agencies have. The other area, to be watchful for is in hospice. I think we've entered into a new era of oversight, and it's not just in California and Arizona for the great concerns that exist with the surge in growth and the number of hospices there, but Congressman Blumenauer, now retired from the state of Oregon, left us with a legacy of a proposed major set of reforms to the hospice program that include program integrity measures, payment system reforms, and even other operational kinds of things. The maturity of the hospice benefit is undeniable. 1 out of every 2 Medicare decedents on an annual basis will have received hospice. So that's going to garner absolutely some attention. When we move to the Medicaid front, honestly, the BBBA, the big, beautiful bill that it is not beautiful when you look at it from the Medicaid context. And while there are no specific home care related cuts or changes within the bill that are harmful to the home care community, the history tells us that if states are going to go through significant reductions in federal financial support in any sector, it could have an effect on home care services, since home care is a discretionary program. So an absolute need for significant 50 state advocacy, plus Puerto Rico and DC in the mix of that as well. And then when we look at overall policy kinds of things, I would be looking at where's telehealth going? Are we going to see finally some permanency to telehealth? And this guy is a better on that, would say yes, for sure. Hospital at home, has a lifespan which continues to get extended, but it deserves to be part of the fabric of the Medicare program on a permanent basis. I give it a better than even chance of happening, but it's going to be in play for the next 2 to 3 years. And then a lot of the personal care services marketplace is watching one other regulatory matter, and that is the Fair Labor Standards Act and the proposal of the administration to remove the regulation which changed during the Obama administration that essentially eliminated the overtime and minimum wage protections that the home care community had relative to services provided in the home. A foundation that was built upon actually Democrat ideals of protecting vulnerable patients from high cost of healthcare services. Tough societal choice made between worker and vulnerable patients population, but this administration currently has proposed to rescind that change that occurred back in 2015. So one would have to say it's going to be a busy 2 to 3 years.
Yeah, understood. We're gonna see now that you laid that out. Let's transition to addressing that. So, Dave, how could advocates better influence state and federal policymakers to prioritize the home care funding and access?
Well, Mike, that's a really good question. But I think we've got a lot of history to show that when we raise our voices, we see some action. Over the last 15 years that I was privileged to be able to manage the Hearts for Home Care team, we saw that the more feet that we put on the ground, the faster our responses were, and the return on our investment was significantly more increased. But I think I can give you a few ideas on what our advocates should be doing. Number one, we should frame our message so that it's a protection of the healthcare system. Secondly, we should make sure that our ask is very clear and simple. We want to make sure that we provide one funding request, one offset or savings, and then one easily understood consequence of our action. Don't try to oversell. Number three, and this is, I think, very important when you're talking to a legislator, is to make the argument around the workforce, because the workforce and our caregivers and our patients, because they're constituents, they vote, and that's what's very important to our legislators. Don't make it about the agency and the impact it's going to have on the agency. But I think the most important thing is to make sure you bring the right voices and the right story. I had a legislator one time tell me that, Dave, you could come in and you could talk to me all day about with data and statistics and show why I need to do something about your challenge, your issue. However, I'll probably forget most of it tomorrow morning. However, if you bring in, and that's not just because of me, but if you bring in someone whose story will resonate with me because they are someone that I'm about to make a decision about that will affect their life, or I made a decision that impacted their life, I'll never forget that story and I'll never forget that individual. So it's important to bring in the right person. And then the last thing that I would probably say is that once you leave the office, don't just walk away and think you've done your job. Continue to keep engaged. Invite that legislator to a home visit. We had one time in North Carolina a state senator who was opposed to almost everything that we did. And we finally got him to come to a home visit. And when he walked out of that home visit, he became a champion for us. That's 2 years later, we named him our state champion of the year.
Before we move on, Bill, anything to add on what our advocates?
Well, yeah, I'll add some things, but I'll echo a few things. And I put at the top, I think what Dave did as well. You humanize your advocacy. It's be very rare for someone to walk into a legislator's office or regulator's office and not find people who have had a direct experience with healthcare at home, with a family member, generally an elderly family member, perhaps, but everything from home health to hospice and private pay personal care services included within that. So humanizing it makes a big difference and allows you to make a great connection. I put into the second a list of my things: noise, 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 noise. There are 3.5 million people who are working to provide home care services. There are tens of millions of people who are doing supportive care for loved ones, which is home care as well. It may not be paid for by Medicare and Medicaid, but they can be partners in the advocacy as well. And 14 million individuals on an annual basis receiving some form of home care. That's a lobbying force that needs to be harnessed. And great credit goes to Hearts at Home and Dave, your efforts as well to take Beata to that higher level of engagement from the staff within the organization. There are other like-sized companies who are working on the same, maybe with similar or sometimes lesser success, but we've only harnessed a bit of the power of that noise that actually is out there for individuals. And I guess I would echo my final comment would be really to echo what Dave said about this is not a one-off deal. I mean, this is continual. And the moment that you leave that lobbying visit to a member of Congress or a state legislator, somebody else is walking into that office trying to convince that same person to advocate for them, in their vote before the Congress or before the state legislature. So you've got to be there repeatedly, not to a point of annoyance, but of reinforcement and support. And, well, Dave, while statistics and data may not matter, certainly in the early stages, you do have to be prepared with that information that when you have taken that member of Congress and turn somebody into an ally, they need to be armed with that as they move forward and advocate for you. Last but not least, Dave, your comment about the home visit. I'll never forget. Home health care was in the battle of its life on an effort to restore 20% co-payments in the Medicare home health benefit. Newt Gingrich, at the time from Georgia, a member of Congress, was Speaker of the House, and he was going to be supportive of it until we brought him on a home care visit in his district in Georgia. And he became a convert at that point in time to become an ally for home care. It is very impactful to have that face-to-face between an elected official and one of their constituents who's in need. Very, very difficult for them to do a 180 once they leave that home. So a lot of power lies in individuals, that are not professional lobbyists, to be able to carry those kinds of messages forward, open those doors to that communication, and to have themselves turn into the resource. Dave, I would have to guess that many members of state legislators and members of Congress have called you with questions on what they should do, because you've developed those personal relationships. So you become the funnel of all that noise and keep heading it in the right direction.
Yeah. And again, when we talk to our advocate base, we always, you don't have to memorize these facts and data. We tell everyone, if you're a listener and you're thinking like, how am I going to do this? How am I going to have a meet? Your direct constituent federal and state legislators want to hear from you. They really do. They generally, if they're not hearing from you, they're scared and like, why don't people care about this? So you're voting them in, bring them this information that Dave and Bill are talking about. The thing that you really have to own in these conversations as an advocate is that story. And you own the story because it's yours. It's your personal story. The facts and data, you're able to read that right off sheets. That's not, don't be embarrassed or whatever. Every meeting I have, I'm not memorizing 4 forms of data. So be comfortable in your personal story being the thing that carries you over. All of our listeners, and if you want any more information, you could always reach out to us.
I think that's important, Mike, that we've seen that legislators want you to help them do their job, actually. Provide them with draft bill language, give them questions for a hearing, provide a one-pager with the data statistics as a leave behind. This all makes most of them are not healthcare professionals.
Right.
And therefore, we as healthcare professionals know a lot more than they do, and they rely on us for that information.
Absolutely.
Yes, so taking on that educator role becomes very, very important. But one other thing to think about, who doesn't talk to their customer? The party who doesn't talk to their customer doesn't have a customer down the line.
No.
And, yes, we can see the patient as a customer, but so are the legislators and the regulators customers. They're the ones paying the bills. So if you don't talk to them, somebody else is going to get their ear instead.
Absolutely. So workforce base, we for years, it's shrinking. Access to care is definitely an issue. So to pivot, again, we're not getting the funding, et cetera. So Bill, like, how do you see technology like telehealth, remote monitoring, AI? How do you see that shaping the future of home care based on what we know on workforce shortages?
I'll never forget that my own congressman back from Connecticut decades ago said to me, there's technology in healthcare at home. And it was like, boy, have we done a lousy job if we didn't get them to understand what it was. And this was 3 decades ago. And today, in the absence of technology in healthcare at home, I don't think we would be anywhere near as successful, as efficient, as high quality as healthcare at home is, be it home health, hospice services, and everything else in there. It's technology which has driven the hospital at home opportunity. Think of that advance, that we now have a hospital level of care in an individual's own home. There's no sector that could say they could operate in any and all settings beyond healthcare services at home, and technology's the reason why we are there. There's no doubt it's bringing efficiencies. It has brought some program integrity risks as well, particularly around telehealth and billing for those kinds of services. So guardrails are certainly necessary. But when we talk technology today, we would be certainly, fish out of water if we didn't say AI as part of that conversation. Right. I mean, artificial intelligence is just infiltrating or supporting our every facet of life, including home care. And that certainly brings questions into what value and risks it may bring into healthcare, and in particular healthcare services in the home. And so I take AI and I put it into my tool chest. Yeah. I mean, I have a wonderful amateur woodworking workshop of tools, but in the absence of this brain and these hands, those tools will just sit in a box downstairs. Yeah. So AI becomes a tool, and I think we're learning so much about what it can do as a tool, but we keep getting reminded that it is absolutely a tool. It's not a decision maker. It cannot reason, certainly at this point, of its operation. It could actually, though, help improve quality and improve efficiencies. So I've become, a student of AI. Yeah. I'm probably in the kindergarten level for gaining knowledge of that, but I am very excited about the opportunities that it may bring, provided we continue to think of it as a tool. It's not going to decide what the patient needs for service, although some people may push it that way. It's not going to decide the greatest path to efficiencies, because we know that the greatest path to efficiencies in healthcare is no healthcare. We can talk to insurance companies perhaps about that modality of care a little bit more. But if there is any sector that should be fully embracing, the today's technologies and tomorrow's technologies, it's healthcare services at home.
Yep. And so we have the depleted workforce. We now add some artificial intelligence and some remote technologies. Well, Dave, like what are the most pressing barriers to ensuring equitable access to home care services for these vulnerable populations?
Mike, before I answer that question, though, I just want to go back to the very first question, which was, what are we looking at over the next couple of years that might be important? And I think Bill did a great job of summarizing most of the major ones in our key practices. But there are a couple there that there's one that's on the horizon right now in the next 2 or 3 weeks, and those are the Affordable Care Act subsidies. If we don't address those in the next couple of weeks, we're going to have a government shutdown, and that could trigger the entire discussion about healthcare in 2026. But looking even beyond that, the Trump administration just recently announced a rural health transformation program that is providing like $50 billion in funding for rural areas. And I just read where 20% of the U.S. population lives in rural areas. Now, that sounds like $50 billion. That could be really significant. However, the details of this program haven't been really discussed yet. There's going to be work requirements, and we all know that work requirements out in the rural areas are very difficult. So that may have a significant impact on access to care in the immediate 2026 future. The other thing I just wanted to mention also, and Bill, you might have some additional information on this. I saw where there's a bill that's been introduced, Home and Community-Based Services Relief Act, which would increase the federal match for Medicaid by 10 percentage points. I don't think that has much legs, but if it did, that could significantly impact the way the states treat their budgets with the upcoming, HR 1 cuts that are threatened at the end of 2026 and into 2027.
Yeah, and there has been previously something very comparable to that 10% federal matching increase that did expand healthcare at home. It occurred part of the Affordable Care Act time period, where states were encouraged to adopt home and community-based services care programs. But I think you're right, Dave, in raising the question: does it have much of a lifespan that's there? If it does have a lifespan with this particular Congress and this administration, it's going to be because home care HCBS has proven itself to be a savings in the Medicaid program. A dollar spent on HCBS avoid dollars spent on higher cost institutional care, which is why we have such great use of home and community-based services. But there are quite a few states out there who lag behind the Oregons and the Washington State and California and New York and New England states in terms of using HCBS as a way of avoiding institutional care. I know where I would not retire to live if I needed home and community-based services. I know which states, but I won't offend anybody by naming them. The data is available to do so.
All right, Dave, want to pivot back to some barriers?
The question about workforce or access to care barriers. And interestingly, over the last, say, 20 years, the same things that are barriers then are still kind of barriers today. We still have workforce shortages, significant workforce shortages caused by similar things that we had 20 years ago: competitive wages, no real immigration policy at the federal level. We have a weak pipeline, so limited career growth. All of these are still barriers to access to care. The one area, though, that I think is something that we have to address, and something that I've been able to get involved in just in the last several months, is the fact that many of our folks who are authorized for care at home, their homes are not retrofitted for care at home. And there is no really federal policy or reimbursement policy that makes that possible. Do you know that the most significant reason why elderly are hospitalized is because of falls? And that's primarily because their homes are not retrofitted for proper care at home. And so I think that if if anything, one of the things that we can do to provide better care at home would be to provide more support for the non-caregiver functions of maintaining care at home.
And Mike, when I look at the barriers now as one of the aging Americans from the baby boomer era and trying to set myself up hopefully for a safe and non-infirm lifespan going forward, I include the complexity of the system that's out there itself, just navigating it, understanding it, personal experience in enrolling in the Medicare program. It took me 5 applications before the system included me into the Medicare program. The joke started that I must be somewhat being blackballed from the lawsuits that I'd filed against the Medicare program in the past, so that they were trying to create nothing but difficulty. But I don't believe that, but I believe that there's tremendous amount of complexity. And Dave, you brought up the workforce issue, and a matter that you and I both worked on along with others is the image of the workforce that needs to be improved upon. These are special caregivers, but they have an image that's not what it should be. They should be recognized for the high level of professionalism and the difficulty of the job that they have, and something that healthcare professionals should aspire to, as compared to thinking, oh, it's some sort of babysitting that's happening there along the way. To send somebody out to an individual's home, independent of all the institutional supports that might be offered inside a facility, creates great challenges for professionals, and the home care workers are up to that. And I think, again, they should aspire to it. And then I had one last thing. There's a knowledge deficit within healthcare that continues. Just as members of Congress need to be continually re-educated, so do other healthcare sectors and healthcare professionals. Whether it be doctors or nurses or healthcare administrators, but absolutely managed care plans need to be educated on that, where healthcare services at home are absolutely undervalued because it's 2% of their total spend. So why put any real money into that? Well, it's 2%. It might affect 50% of their spend along the way. And unless we can solve that Medicare Advantage and other managed care issue out there, we will continue to have these barriers there. And it's not all prior authorization. It's payment rates to the providers of services as well, in addition to the navigation of where patients should be counseled to go for services, whether it be the home setting or otherwise. So we're making progress on that complexity and those barriers, but it's not an easy task, and it is like advocacy, right, Dave? It's a different form of advocacy, another one that's needed 24/7, 365.
Well, one thing I've noticed over the last, say, 15 years, the awareness level of what we do and how we do it, and the savings that we can provide, and the satisfaction levels of those who we treat, that's increased significantly. However, unfortunately, the actions that are being taken by many of our states and the federal government to continue to improve care and access to care has not increased at all at that same level.
No. It's as if we've got two different mindsets there. The health policy focus on healthcare at home continues to expand, whereas the healthcare financing of healthcare service at home continues to present challenges. So, whether it's two-faced or whatever, I'm not sure how to best describe it, but it is so 180 from one another.
Yeah. What you said about 5 times trying to enroll. My wife is a nurse. I'm in home health care for 30 years. We get questions all the time from friends about enrolling in different plans and et cetera. And when we're helping them, it's daunting. So I can't imagine the people that don't have people like us and you to help them too when they have questions like this. It is so intimidating. And sometimes I think that is actually an underlying effort that institutional care happens instead of home care, because the frustration just becomes maddening, and they have nowhere else to go, and they give up. So the education is key. And what both of you talked about in terms of education to the lawmakers, that's the one thing that is extremely daunting for all of us as home care advocates, is they change. We keep going to the Capitol Hill in DC and state capitals and talking about this. Well, then the legislators change, and you have to re-educate. So that's why we keep, reinforcing, all of you that are listening, et cetera, is yes, go visit your legislators. They need to be made aware of this, because they're changing at all times, and they need to keep being informed. Innovation. Okay, so now we know we're lacking a workforce. We're lacking access to care. The walls keep closing in on us. So let's talk about, is there an innovative funding model or something in a reimbursement strategy that can support these home care services and make this a little easier? I guess it's on us.
I think it is on us, to take advantage of what has been created, and, when you look at anything in life, there's going to be some form of competition. And my view being that home care was best positioned to take advantage of innovation as it developed, but perhaps the stresses, the tensions that we've already talked about, got in the way. And people just tried to keep their head above water on a day-to-day basis, and we're not embracing some of the innovations. But a perfect fit for healthcare at home, is value-based purchasing, VBP, value-oriented delivery of services, shared risk among providers of services. To say, I know that I can deliver better than any other source of healthcare. And so, share with me the value that I bring to you and incentivize me to do so. I think that's not going to go away. It may change what it looks like, getting more involved with ACOs, accountable care organizations. And home care is in the room, but they're not necessarily at the table as they should be with ACOs. Physicians may be the drivers there, but physicians and home care are natural partners in all of this as well. Then when you're looking at other kinds of things in bundling and flexibility, Dave, you mentioned, the ability to do home renovations, to be able to create the opportunity for people to come home. There are some authorities in Medicaid to be able to spend money that way, but some more flexibility as an innovation with a bundled kind of payment approach could go a long way to bringing people the option of being at home, or even the option of leaving a nursing home and coming back home, because most often people think you're admitted to a nursing home and that's the end of life as you know it outside of that facility. And frankly, that's not the case. And then what's odd that's on my list here of talking about innovation is not something which is brand new. It's called the PACE programs. PACE has been around for, 35, 40 years now. Started in the San Francisco area with a program called ONLOK, ONLOK, 2 words on that. It is getting its attention of late, but it is a perfect fit for a population that's aging like ours. I find a little bit of a frog in my throat when I say aging like ours. I should say aging like me. I actually have a birthday coming up later this week, and so it's on my mind. I won't tell you how old I'm going to be. You can only be 29 for so many times before people start doubting it. But PACE, centers everything around managing a lot of chronic illnesses, managing the whole patient overall, managing the patient in the least restrictive environment when possible to do so. But there are only a handful of PACE programs across the country. I don't necessarily hold myself out as a highly knowledgeable on that business model, but there might be some business model updates that could be done to make it more attractive just to develop one of those. Dave and I are going to create our own PACE program, but it's self-serving. That's why,
Let me add to what Bill said there. Certainly the VP programs are something that have had great success on the home health side. And we've seen some states even looking at it on the Medicaid side. But the PACE program, I think, is something that I personally have had a chance to get to know a bit better over the last couple of months. I actually visited a couple of PACE centers just recently and spoke with some of the members, the participants, who universally were thrilled with the opportunity to come together every day, and all the services that they needed, whether Medicaid or Medicare, were bundled into one location. But they also the ability to interact with other members in their community and enabling them to stay at home. I think that this program, which largely is, as Bill said, on the West Coast, and it's just getting started on the East Coast, is a very innovative practice that's saving quite a bit of money for our healthcare system, but also enables folks to stay and live sustainable lives in their community.
Yes. Well, as we close the conversation here, you've both dedicated a great amount of time in your professional careers advocating for better home care experience for consumers and the caregivers. So, Dave, let's start with you. Can you provide some personal reflection of what you've seen and what you think is to come for the future of home care?
Sure. And as you could tell or think, I've spent a lot of time thinking about that over the last couple of weeks, particularly as the clock starts to tick down. And, I was thinking about when I first got started with advocacy, which was prior to actually joining Beata. I'd been involved with my prior company for about 4 or 5 years. But similarly, advocacy in healthcare was primarily a couple of folks who walked the halls. It was really direct lobbying. It was you employed a lobbyist, or your company had one or two people, and you were involved mostly with education issues, training, talking with legislators about what you needed, some of the issues that were of concern. The message over the last 20 years hasn't changed very much. We're still underfunded, as we know. We've had long lapses in adjustments of rates. We've had too many legislators who are trying to claw back funding from previous increases. We still have lots of misunderstandings about our margins and the rate methodology. So none of that has really changed. What has changed, though, and has changed, I think, rapidly, is that our tools have changed, what we have to work with. As I said, when I started at Beata and then we formed Hearts for Home Care, we were virtually a very small group of people, a couple of people, actually. But today, we actually have 3 different units there. We have one that's focused on the public policy and lobbying effort. We then created, actually under your leadership, Mike, the industry-leading grassroots effort across the country, realizing that we had a lot of voices within our organization that wanted to be involved, but no one was tapping into that. And then thirdly, just recently, maybe 4 or 5 years ago, we realized that the whole consumer base out there is someone who needed to be involved, had to get involved because they're constituents as well. So we created a public affairs and social media team. In fact, our public affairs team just last year generated over 125 million impressions, something that's significant across just for one organization. So today, advocacy is not just a couple of people. It's really a multifaceted public policy and communications effort across the board. Going forward, I think it's just going to get bigger and bigger because more and more folks want to get involved. But we're going to have to be able to use data much more effectively, targeted towards specific needs of legislators. And then the use of AI, as Bill indicated, is going to be a great asset to us. It's not going to replace people, but what it is going to be able to do is to allow people to do more of what they should be doing rather than a lot of administrative work to prepare for an individual meeting.
Bill, what's it been?
My tenure with due respect to Dave, is a lot longer. So my comments might take a lot longer, but may not be as insightful as his. But, healthcare at home has been around for 125 plus years. Way back in the turn of the 19th to 20th century, we had home care services at home provided by public health agencies, VNAs, and others dealing with chronic illnesses like tuberculosis, Spanish flu, and more. Nurses going door to door, to provide high quality services. But between, say, 1900 and 1990, maybe, we had very little home care services. My first entry into this world of home care was back in 1976. And I took a summer position at a public interest law firm. The Connecticut Legal Services is ultimately the name that became. And they wanted me to play softball because we had almost won the championship the year before. So they wanted me to come back after my first year of law school. And so I said, I need a job. So they said, well, we'll figure something out. Well, when they figured it out, they handed me a responsibility of checking to see what are the issues in healthcare, particularly Medicare and Medicaid, that we're not dealing with at that public interest law firm. And so I focused in on Medicare skilled nursing facility coverage and Medicare home health coverage. I visited every nursing home in the state of Connecticut and almost every home care agency in the state of Connecticut as well. And what I found at the home health side of it was opportunities abounding to be more available, better, opportunities for services to aging individuals, along with a passion from the home care community that was patient-centered, 110% patient-centered. As a knee-jerk liberal advocate, at that point in time, I found partners, in home care, and their passion, grew within me for many, many years to come. But let's just talk about historical. Back then, there was no Medicaid home and community-based services at all. Today, it's the largest long-term care program, not just in the US, but in the world, providing long-term care services with a focus on care in the home. There was no hospice benefit. In fact, there was barely any hospice in the United States at that point. Connecticut Hospice was the first hospice that was created, but that was even pre-Medicare benefit. Today, as I mentioned, 1 out of every 2 Medicare decedents are using hospice services. More patients are receiving Medicaid HCBS than care in a custodial nature in nursing homes by a factor of 4 to 1, growing to 5 to 1. And there was about 300,000 people receiving Medicare home health services at that point in time. And today it's over 5 million. So we've talked of barriers. We've talked of, all these difficulties that are needing advocacy. But it seems to me that for every one step of difficulty, we've had 2 steps forward of positive created opportunities along the way. And not only has the healthcare world shifted to home care in the US, it's worldwide. I'll never forget the day I spent with a delegation from the Chinese Health Ministry, none of whom spoke English, or at least willingly spoke English in my presence. Instead it was all, translated. And imagine when they asked me a question about the Medicare payment model for home health, how that translates quickly from English into Chinese in that way. But the Chinese were recognizing at that time that they had misunderstood value themselves and thought that the way to value their elders would be to give them the opportunity to get care in a hospital, only to realize, taking someone out of your own home, putting them into a foreign building, where you've got all the stuff that goes on, that doesn't make life very comfortable, is not the way to honor anybody, but care in the home is a way to honor people along the way. So this is actually a worldwide movement towards care when you start looking over the last 3, 4, 5 decades. And yeah, my tenure gives me the privilege of being able to have experienced some of those kinds of things, but also I think sends a message going forward, particularly to the people who are now my children and grandchildren's ages. Invest in care at home. The return on that investment will pay dividends for everyone, not just the patients, not just dollars and cents, but dividends to humanity, so many ways. So if I'm proselytizing a bit about care in the home, maybe we have the choir sitting and listening at this point in time, but I see the future as extraordinarily bright. And I only hope, Dave, that the future recognizes the impact of people like yourself, in creating that opportunity to be where it is. I may never forget Mickey Mantle. Hopefully no one will ever forget Mickey Mantle, and hopefully no one will ever forget the foundation of healthcare services at home and the advocacy movement that has occurred over the past couple of decades.
Well, Bill, when I was privileged to be able to give you the Hearts for Home Care Lifetime Achievement Award, was a year or so ago, I did mention the fact that no one in our industry has had their fingerprints on almost every important piece of legislation or regulatory change regarding home care as Bill Dombi. So,
thank you.
We appreciate everything you've done.
Thank you for that. Maybe I'm just a shoplifter stealing, applause from other people's good deeds. But I will say this, in my trophy case, next to that award is the one I got when my softball team did win the championship that year when I was back in law school. No, I didn't get MVP. I got Coach of the Year, which no one would have believed. I typically got thrown out of games as a player, but got to sit on the bench still as a coach. The passion that I have, for that game, is still small compared to the passion I have for care at home.
Yeah, the Billy Martin of the law school, of the law firm team. I like that. Yeah, getting kicked out. That's good. Well, thank you very much to Dave and Bill. Pod people, I hope you really appreciate this as much as I do. This was great insight to what's to come, what has occurred to get us there, and how much more there is to go. And reach out to us. We'll get questions to Bill and Dave if you have them, and get back to you. And to everyone listening, stay tuned for the next episode of Home Care You Say, coming up shortly.